Okay, I think everyone's getting settled in. Good afternoon. My name is Nicole Clark, and I'm the Senior Manager of Patient Advocacy with IDF. Just before we get started, want to remind everybody and talk about the surveys that we conduct to evaluate IDF National Conference. You should have received an email prior to the conference with a survey link, and we thank you for completing that pre-conference survey. We will also be notifying you post-conference where you can provide feedback on this session and all of the other sessions that you attend, and that you will be notified through that with the app as well if you have downloaded the app. We thank you in advance for completing it. Your feedback is absolutely vital as we do understand the true impact of our conference. I'm not sure if the kids are behind us. Any questions will be answered at the end of the presenter's talk. I've handed out some index cards. There's some more on the table over here and up front. If you have any questions, you can write them down. We'll collect them and do a brief Q&A at the end. So now it is my pleasure to welcome you to the Health and Life Management session, Chronic Sinusitis, Chronic Sinusitis, Chronic Sinusitis. Why does it keep coming back, and how do we deal with it? This session will be presented by Dr. Ralph Shapiro. Dr. Shapiro serves as Director of Midwest Immunology Clinic, is a clinical assistant professor at the University of Minnesota, and a member of the IDF Medical Advisory Committee. So please join me in welcoming Dr. Shapiro.
Well, thank you. I appreciate the IDF asking me to come give a talk. Here we are late in the day. Everybody's tired. I'm going to try to make it interesting. But when I first was asked to give a talk on sinus disease, how on earth can I make sinus disease interesting? So I try, and it'll be fun, believe it or not. But I think it's going to be informative and help us understand what sinuses are about and how they work and why it's so difficult to manage them, because it really is. So I think back to my dad. He always had these great phrases and stories and everything else, and I used to ask him, "Dad, how does the nose work?" And he'd go, and that was it. So it didn't really satisfy my curiosity. But he also had another saying. He said, when you're sitting with your honey and your nose is kind of runny, you may think it's kind of funny, but it's not. And so when I thought about talking about this, it brought me back to my dad. So it means a lot to me. But there's nothing funny at all about sinus disease. First of all, it is a huge expense medically. And I didn't get updated statistics, but as of 2014, it was estimated to be about $9.9 billion in healthcare costs goes to treating sinus disease. This is a major problem for everybody. Anyone who's ever had a sinus infection, it just takes over your life. You cannot function. And it's really devastating. So you can't work, you can't function, you're short with your friends and your kids. It's hard on relationships. It's a major problem. Urgent care visits, surgical procedures, office visits, prescription medications. It's a big expense to the whole medical dollar. There's a lot of indirect costs which aren't even in that, and that is the decreased productivity, lost work, not being able to go to school, not being able to learn in school. These are major things. So sinus disease is serious, even though people try to minimize it. So why do we have sinuses? It's kind of dumb. If they keep getting infected, why do we have them? Well, no one really knows. We think that it has to do with baffling air. So when you breathe, the air circulates around, picks up moisture so you don't dry out your membranes, and that's one function. It also lessens the weight of the head. If we had solid bones and not holes in our head, we'd have a hard time holding our head up. When you get a sinus infection, you have a hard time holding your head up anyhow. It improves our voice and our speech. It does absorb shocks to the face or the skull, and it secretes mucus, and that's really an important thing. And so we'll talk about what mucus is and what it does. So here's just a diagram showing sinuses. And you can see there's these big holes on either side of your cheek. between your eyes, up above your eyes, and if you go backwards a little further, you see there's right in the middle of the skull there's sinuses. This is actually a CT scan showing the openings. The black is air, and you can see it's like a maze. You should have an opening that you can go out and come down and drain into the nose, and that's open on both sides. These are very nice clear sinuses. When you look, like I said, in the middle of the skull are this ethmoid sinuses. They're right between the eyes. And if you go further back, the sphenoid sinuses. When these get infected, you get a horrible headache. And sometimes you don't have anything up in the maxillary sinuses. You're not necessarily blowing out a lot of stuff, but it's like this horrible deep headache because it's right in the center of your skull. The whole mechanism in the sinus is related to cilia. Cilia are little fibers that are like fingers that move. It's like carpet here. And these little fingers have a very important function. They're the ones that move mucus inside our sinuses. This is another picture. You can see these big, tall cells. They have these hairy fibers on them, and they beat rhythmically. They beat about 700 times a minute. So these are very active little things, moving, and it's a cushion. So you have those cells in there, and they're very important. And if you look on the top here, here's all the cilia. Then there's these yellow cells. So what are those? Well, that's actually what produces mucus. So there are these globule cells that secrete mucus up on top. There's a cilia that moves all these beats per minute, and this is like a river that floats on the surface and moves stuff out. So if you get a particle like this that comes down and lands in the mucus, it's moved. It's moved and moved so that it gets out, so you don't have junk accumulating in your sinus. It's very important. And actually there's a video, and I'm not technologically savvy enough to put it in here, but I wish I did. It actually shows a particle on a mucous membrane, and you can watch it over time move across the membrane. So this stuff really is active, and it's very important. So you have another picture of the mucus-producing cells and the cilia. Here's a picture. It's like a river moving stuff down the drain. And the sinus is built in a very weird way. It's upside down. We have mucus that moves stuff up, and drip down the back of the nose. So that's how it works. It goes against gravity. So we're upright, and it's anti-gravity. So why would it be designed like that? It's probably because we were designed to be on our four legs, but now we're upright. But nevertheless, stuff that doesn't get out sits in there and gets infected. So you get mucoid discharge. The snot comes out, and that means that the passages are open. They're able to get the junk out. That's good. If it doesn't come out, you feel it. Now, inside the mucus is a very important part of our immune system. We have antibodies that are secreted into the mucus that help protect us. It's called IgA. And IgA has two antibody molecules that are attached by a J chain that joins them. And then there's a secretory piece in the cells of the mucous membrane that actually secrete the IgA into the mucus. So here, if you look at the green, this is actually the lining where the cells down below that make mucus are, and you can see all the IgA in the mucus. And then it's secreted out onto the surface where the cilia are, and these IgA antibodies are there. So you can imagine this is an important way to protect your sinuses from infection. And if you have antibody deficiency and don't make IgA, you have a problem. So usually it works that you start with a little runny nose, and you think it's just a cold at first. Then it gets worse, and you get inflammation. It can be caused from a virus, allergies, irritants, and it may not end there. These things can go on and get infected, and then you got a full-blown sinus infection. So when you get inflamed in the sinus, it increases mucus production. The cilia that move stuff through, they stop working when you get inflammation. You decrease your ventilation and mucus transport, and the cilia just slow down. Instead of 700 beats a minute, they may only go 100 beats a minute. It's not a very effective way to move stuff. You get obstruction of the openings because you get swelling in the sinus, and you get mucosal edema, and you have a hard time getting the junk out. So if you look here, if you have a maxillary sinus and swelling and inflammation in the tissues, it blocks that opening. You can't get stuff out, and so it fills up with pus, and that's a sinus infection. Here you can see this one where it's filled and there's an air level here. This side just has swelling and inflammation. So it's a process of inflammation leading to infection. And then you got a full-blown sinus infection, which is miserable. So some of the symptoms, I think everybody in this room probably knows. You get a stuffy nose, you get pain, you get pressure around the face, your teeth can hurt, you get colored discharge out of the nose instead of clear stuff. You might get wiped out and tired, you have decreased sense of smell, you start coughing, you get bad breath, you get headache. There's nothing fun at all about sinus disease. Now we classify sinus disease into two types, actually three. Acute, which is just a very short course. It's in less than 4 weeks and hopefully goes away. There's subacute that lasts another couple of months sometimes, and that's called subacute. And then there's chronic. Chronic sinus disease goes on for months and months, sometimes even longer. And this is a miserable problem. And it's maybe a different process than acute sinus disease. So there is some importance in how we manage these things. And then recurrent, we usually say, is someone who has 3 or more episodes of sinus disease in a year. That's more than an average person does. So usually that's a hallmark there's something wrong, and it's up to us to figure out what that is. So in acute sinus disease, this is usually caused by bacteria. And these are caused by bacteria that are called encapsulated. On their surface, they have a fuzzy coat of sugar, and that protects them from IgA. And so they love mucus because they can hang out there and they don't seem to have much trouble unless you have good IgA. And these are the encapsulated organisms, and this is a picture of pneumococcus. Here's the fuzzy coat of sugar and the wall of the bacteria here. So you can see it on the side that it is fuzzy. So these are the bugs that cause a lot of sinus and respiratory tract infection and pneumonia and bronchitis. So they're common bugs, and we know how to treat these. That's why when you go and you get an antibiotic for an infection, we can guess it's probably one of these bugs if it's an acute sinus infection. Now that's very different if it's not acute. So it's important that we distinguish that. Now we give vaccination that helps protect against pneumococcus, one of the encapsulated bugs, a very common one. And we give 2 types of vaccines. There's 3 listed here. We don't use the 7 Prevnar anymore. But the 23-valent Pneumovax is a pneumonia shot that a lot of people are familiar with. That's a pure carbohydrate. And it's hard for people to make antibodies against that if they have antibody deficiency. So that one may not be effective, and it's one of the ways we diagnose immune deficiency. The 13-valent conjugated vaccine is a Prevnar 13, and that's what's being used now. Now, that is a trick we play on the immune system. We take the carbohydrate, the sugars, and attach it to a protein carrier, and then vaccinate with that. And the body thinks it's a protein and makes a better antibody response. So some people that have specific antibody deficiency and can't make good antibodies to carbohydrates, we can give the Prevnar 13 and trick the immune system to make an antibody and protects them. So there are ways to protect in people that can respond to these vaccines. Now, how do you treat acute sinus disease? Well, supportive care is what normally is done in a doctor's office. They're going to give you saltwater rinses and blow your nose, antihistamines, expectorants, things that actually just treat the symptoms and help you get through it. And that works okay. Antibiotics are not helpful for patients with mild symptoms and really are not prescribed. And most doctors won't treat a sinus infection in the office because we're really trying to hold back on overuse of antibiotics because people in this room need those antibiotics. And that's the real reason, so that when you need them, the bugs aren't resistant. So if you have an immune deficiency, we usually treat, and I treat early. I say 3 days of progressive symptoms for sinus disease. You want to get on something, because if you don't, it's going to go on to be a prolonged course and much more difficult to get rid of. So if you're prone to sinus disease because of an antibody problem, we have different rules. So why do we get so much sinus disease and immune deficiency? Well, this is kind of a silly story, and I think it's illustrative of what goes on. I think about the sinus as a big room, and in that room there's food laying out on the table. And in the doorway you have this big bouncer standing there. That's IgA. That really keeps the bacteria from coming in and eating the food in the mucus. Well, people with immune deficiency don't have a bouncer. They're low on IgA. They may not make good antibodies, and they got a little wimpy guy. So if this wimpy guy's standing in the doorway, they don't care. They come in and they start eating the food and they start having fun, and they call their friends to come down and have a party because there's nothing to push them out. You don't have the ability to keep the bacteria out, and it ends up being a food fight. You have a full-blown sinus infection. It's awful, and that's what's going on. So you say, I need help. So you call the doctor up. They say, okay, I can give you a bouncer, writes a prescription for an antibiotic, gives you the antibiotic, comes in and cleans everything up and kicks out all the bacteria and puts all food back on the table. Everything is great. You feel good. You've been treated for your sinus infection. Okay, so you stop the antibiotic because he only gave you 10 days worth. Well, guess what? You still got a little wimpy bouncer. And the whole process starts again. And that's what happens with people with immune problems. Those sinuses are prone to infection because the environment is such that it allows bacteria to grow. And unless we do something to change it, you're going to always have sinus infection develop. So this is a big concept that I think is important. Now, if we talk about chronic sinus disease, this is what we try to avoid because this is a much more difficult problem than acute sinus disease. It's much easier to treat infections as they come up and keep them from getting to this point. But once they do, we're not even sure that this is an infection. This is a process that sets up in the sinus that is difficult to treat and really a different process. You know, if you look at it, it isn't filled with air fluid levels. It's filled with thick, heavy crust. It's an inflammatory mass. And so the lining of the sinus, here we go. It's all thickened in here. It's not that there's pus in there. So you can't really treat that very easily. It's like rubber. And we used to call it like glue because when you go in there and scrape the stuff out, it's like sticky and really difficult. And so you're not going to be able to blow this out. And a little salt water isn't going to go in and rinse it out. It's in there, and it's very, very difficult. So this is 32 million cases a year in the United States. It's pretty common to get chronic sinus disease. And it's not clear what this is all about. It gives you pain and headaches, fatigue. You get really kind of emotional, and your significant others around you know that you're not feeling well because you don't. It impairs your activity. It reduces your ability to work, go to school, and concentrate. It's a major problem. It also triggers asthma. So people with asthma that get chronic sinus, you can't really effectively treat their lungs until you clear their sinuses out. So it's something that is really important, and it's probably because the mucous membranes are very similar, and the cytokines and inflammatory molecules affect both membranes in the sinus and in the lung. So you have to treat it. And so we often will treat infection, that's part of the inflammatory process. But the infection is very different than an acute. So if you look at the bacteria that we see, they're different bugs than the encapsulated organisms we see in acute infection. These are bugs that are either growing on surfaces of inflamed tissue or they're anaerobic. That means they grow in low oxygen. And if you get a socked-in sinus, you don't have blood supply to the center of this thick paste on the surface. And so there's low oxygen. So the bugs that grow there a lot of times are anaerobic. So we need different kinds of antibiotics to treat a chronic sinus infection than you do an acute. So how do we treat it? Well, very often you need a pretty powerful antibiotic, and you need to go for a long time, 14 days minimum. There's times we treat 21 to 30 days because it takes that long to really break up this inflammatory tissue and get rid of the bacteria that are part of the process. We often use steroids. Steroids are helpful in getting rid of inflammation and stopping this whole cascade of bacteria and inflammation. And then sometimes we'll use oral steroids. Sometimes people give a shot of steroid akenologue, gives you a prolonged steroid without having to take it orally, and sometimes saltwater rinses. So these things are helpful, but it sure is not like ideal. It works, but it's slow. If you don't clear it up, let's say we treat several rounds, we use anaerobic antibiotics that'll kill those bugs, you still have sinus disease. There's times where surgery is helpful. You can go in and clean out this glue in there and really clean up the sinus and open up the drainage. It's not curative, and it sometimes helps, but often it'll just close up again. So it's not a permanent fix. So what we do is we try to identify contributing factors to this inflammatory process, and if you address those, you're going to do the best you can. GE reflux disease is the most common underdiagnosed problem that leads to chronic sinus disease. It often has very few symptoms. It's just that when you lay down at night, acid washes up into your esophagus, and right along the esophagus there's a nerve called the vagal nerve. And when you let's say you're eating meat and you swallow meat and it gets stuck in your esophagus, you start gagging and coughing and your eyes start watering and you start have all these secretions. Well, you swallow some of that and wash down what's stuck. So your esophagus is protecting itself by triggering this nervous reflex. From the reflux, the esophagus doesn't know that it's not something stuck. It's still something irritating it. And it does the same thing. It causes secretion. So people that reflux at night may not have heartburn during the day, they may not realize it, but they lay down at night and stuff washes up and down the esophagus and you get secretions. You wake up in the morning, you're full of junk and you blow it out and it clears up and then you're fine the rest of the day. But it's usually clear stuff. You're usually exhausted because you're waking up but not completely aware that you're awake all night. All night you're kind of, and you roll around and you come out of that deep REM sleep. So you don't get the restful sleep you need and you're exhausted. And this is a very, very common problem. We look at environment, smoking cigarettes or being around people that smoke, irritate membranes, cause inflammation, allergies, exposure to mold spores. These are all factors in some people. The structures we look at because sometimes there's a block in the drainage pattern. Cystic fibrosis, ciliary dyskinesia, these are problems in either making thick mucus or not being able to move mucus because the cilia don't work. And then there's immunologic causes, antibody deficiency, IgA deficiency. These all relate to poor bouncers, and you're prone to this. So structural problems, I just show a few examples of it. Here's a child that had a cleft lip repair, so the structures aren't 100% normal, and these kids often have chronic sinus disease. People with allergies develop nasal polyps, and these things just hang down like big limbs, and they block the drainage, and this is from chronic inflammation. And then you have adenoid tissue, which in some people block the drainage pattern. So these are structural things that the surgeon can help us with sometimes. And this is another picture of nasal polyps, and you can see how inflamed this polyp is, and the mucus gets stuck under it. It's really a big problem in people with allergies. So how do we treat this medically? Well, we're doctors, we have a pharmaceutical industry, and they love to push drugs because they make money off people. But they are helpful, and you have to use them in the right way to get the most out of them. So we do use antibiotics. Steroids, if you use them in the right way, can be very safe and very effective. There's nothing as effective as steroids for inflammation, but they also are very toxic if you overuse them. So you got to be careful how you use them. Expectorants are compounds that actually make mucus less thick, makes it runny, so it's easier to clear things out. And then decongestants, we'll talk about those, and surgery. So I'll go through each of these and just talk briefly about them. So antibiotics, if it's acute infection, we use antibiotics to treat encapsulated organisms. You know, if you go, there's a whole bunch of different kinds of antibiotics, so even people with multiple allergies to antibiotics, usually we can find something that'll be effective for them. I'm not going to go into all that. So those are antibiotics. Steroids are beneficial. They can be used with antibiotics, and antibiotics may kill the bacteria, but the steroid actually decreases the inflammation, so it allows the drainage to open up, and it gives people relief. And these can be used either as topical steroids where you spray them up your nose, and you can see there's a whole variety of those because they're very effective. We use oral steroids for short courses sometimes, and we do trick with people that have constant sinus inflammation where we take budesonide. It's Pulmicort that you throw into a nebulizer. Well, we take it and put it in salt water, and then we rinse it in the nose. It's a very effective way to treat this, and then we've had good luck with that. Some people use baby shampoo in salt water and rinse the nose, and that cuts down the bacteria. And Bactroban is used by some of the ENT docs as rinses. And then there's antibiotics you can throw in the rinse, and you can rinse your nose. That's expensive, and insurance doesn't like us if we order that. So this just shows the expectorants, what they do. If you look at mucus that's thick, it doesn't pour well. It pours a little better, it gets a little runny, and finally it comes out. And that's what an expectorant does. It tries to help decrease the thickness of the mucus so that it flows. Decongestants are controversial. You can't even buy them now without having to go to the counter and the pharmacist pulls them out because of compounds that are used to make meth in there. And so these are very active ingredients, and they work by stimulating nerves. And so they do have a lot of side effect. People feel better when they take a decongestant because you can breathe better, but it drives your heart. It has some side effect. And if you actually look at studies, it really doesn't make a difference in how long you have the infection. So they're not really treating it. They're treating the symptom. And it's hard to talk people out of using decongestants because you feel better. So, I try to limit it, especially people with heart disease or hypertension, because there's side effects with them. Okay, now we get to chronic sinus disease. This is a whole different ball game. It is very difficult to treat. You want to control predisposing factors. That's always important to think about what are the things that contribute to it. We give nasal steroids for the inflammatory response. We treat with different antibiotics. And, when you do studies, it's hard to know and it's hard to prove that these things are really very effective, but we don't know what else to do. Surgery, we finally get to surgery sometimes, and there's different types of things that are done. Functional endoscopic surgery, it's a major surgery, gives some relief, but it's not a first-line treatment by any means. And there's some newer stuff that are going on. I'll talk about. Here's not that new anymore, but they go up with a little catheter that goes in here, and then they blow up a balloon, and it dilates the drainage. And so it's a non-surgical way to open up the drainage. This works, but it eventually closes up again. So there's no good way. So what else can you do? Well, there's not a lot. Grandma knew a lot, and if you listen to your grandma, they had all these folk remedies, and they worked. And these are passed down from generation to generation. So there is some validity to some of the things that grandma taught us. Tell you to drink a lot of water. Well, mucus needs water, and if you have more water in it, it flows better. It makes sense, and it works. Chicken soup. You get a cold, your grandma would come with a chicken soup for you. Well, it really does help. And laboratory studies show there's anti-inflammatory effects of chicken soup. I think it's the steam and the stuff coming up probably helps as well, but the salts in it may help make mucus move better. We don't know. Hot beverages of any kind, ginger tea, fruit juice, hot tea with honey, these all do help make mucus move better and may help you clear stuff out. So they're worthwhile. It's not going to cure everything. Spicy foods like hot peppers. Anybody who eats hot peppers and starts sweating and have their nose run, this does work. And it is effective. And then you do things like home remedies where you do a steam. Here's someone with a towel over their head, and you can put a hot bowl of water or whatever and breathe in the fumes. And that really does help. Or go in the shower. It doesn't cost anything. It's not expensive. And it does give some relief of the symptoms. And you got to be careful not to burn yourself. And you can put aromatic oils or things in the steam to make it more palatable. Eucalyptus smells good. Menthol is anti-inflammatory. A lot of stuff you can do with those steam therapies. You can use nasal rinses, and there's a whole bunch of these you can get in the supermarket. They have a million different bottles of salt water, and all it is salt water. Some of the people will do things like squirting their nose, so you'll do irrigations where it goes on one side and out the other. This is sort of schematic how it works. And that's a way to rinse out a lot of the stuff in the front of the nose. It doesn't get into the deep sinuses, though. And then there's the neti pot, classic. And not everybody can do this. It's a weird thing to do. But if you know how to do it, it's a very effective way to clean out the sinus and get rid of some of the snot. And then there's a million different things being sold. Nebulizers that'll spray stuff up in your nose and all this. Studies really don't show this stuff to be great and effective. But I know there's patients I have that swear they're helpful. So, if they're not too much of an expense and you feel like it's an easier way to get moisture in your sinus, go for it. But I wouldn't spend a lot of money on it. This is good news. Your HMO says you're feeling fine. Doctors minimize sinus disease. I think we need to make sure they understand this is not just simple sinus disease when it affects you and it's chronic. You really need to be your own advocate and really try to get therapy and help, because there is help. It isn't perfect, though. So the next time when you're sitting with your honey and your nose is kind of runny, you may think it's kind of funny, but you have to deal with it. You can't just walk away from it. It's there. So you do the best you can, and that's the bottom line. Unfortunately, there's no magic to get rid of sinus disease. So I'll end here, and we have time for some questions. Why don't you give me that one to start with? What is your thought on the recent scary news articles regarding the use of Levaquin, which is a drug that works well for my bad sinus infections? Comparable drug to use. Okay. Levaquin has for a long time been known to cause problems in tendons, and there were people that would rupture their Achilles tendons when they're on Levaquin for a long time. Now there's some evidence that it affects cartilage all over, and it can be a problem. All I can say is that you have to put in perspective the risks and the benefits. Levaquin's an extremely effective antibiotic. We've used it for many years very safely. If you don't use it all the time, I think it's okay to use. Now, if you get pain and aches when you're on Levaquin, you stop it. Some people, it never goes away, but I think that's rare. Most often, if you stop it, it does go away. So you can use it if you understand there's some risk. Now, there's other antibiotics that you can use, though. There's a whole bunch. And if you look at where you are in treatment, you can decide on what makes sense. So you don't have to use Levaquin. But I still have patients that won't go without Levaquin because it's the only thing that really works for them. So I use it. I still use it. Just you have to be aware there's risks. There's risks with every antibiotic for things. If there's a role for sinus surgery, recurrent acute sinus patients who experience a new infection every 1 to 2 months. Well, again, it depends on what is going on. It depends how long you're treating it. If it's really acute sinus infection, usually it's treated medically. You don't need sinus surgery unless you're getting it because of structural reasons. Then you can fix the structures, the drainage. It's sometimes necessary. But usually for acute sinus infection, we can treat that without having to do surgery. I always tell my patients, my job is to keep you away from the ENT doc. And if I can do that, it's great. And a lot of times they'll come say the ENT wants to do surgery. I said, you haven't been on everything yet. Let's try the gold standard. And the gold standard is actually a combination of Biaxin and Flagyl, and that covers the anaerobes and it covers staph, and is pretty good. And we get great results. If you fail that, Biaxin and Flagyl. We take them together. 2 pills in the morning, 2 pills at night, and we go 21 days. Now, if you fail that, then I send you to ENT. Because a lot of people, we can get them clear just with that simple approach. But, that's my experience. I don't think there's been great studies on it, but I've used it for years and it works.
What's the dosage?
500 milligrams of each for each dose. 500 in the morning, 500 at night. You can dose it for kids, sure. Yeah, and it comes as liquid. It doesn't taste good, but it can be used. Sometimes cultures are helpful, but when you get to chronic sinus disease, you go up there, you're not getting into that glue. You're getting on the surface. You may not even see what's in there. So it's not always going to direct you. If you get a bug out that is resistant, it can help direct you. If you get a fungus, that helps, and sometimes surgeon has to go up there and try to get a culture. So there is use for that. But again, it's mostly for chronic sinus disease, not acute. I usually go 21 days, yeah. And that clears you up. And there's other times where I will use like a clindamycin, which is a very powerful antibiotic, but that also covers staph, and it'll cover a lot of these anaerobic bugs. Tetracycline sometimes, but these are different antibiotics than you use for an acute infection, and we use them in people that have chronic sinus disease. I was treated for chronic sinusitis with severe postnasal drip with tons of sinus problems in the past. ENT did scans of my head. My left maxillary is hardened. I'll always remain partially infected. This was in 2002. Is there things other than Neti pot to use, or have there been significant advances since then? I put together this talk for the IDF meeting, I think it was 6 years ago, and every time I give it, I update it, and unfortunately, there's very little update. We just haven't made much advances. There's a lot of work going on into what it is that drives this inflammatory tissue, and talk about ways to address it, but we still don't have any major advances. Now, if you have eosinophilic sinus disease, it's different. Sometimes you go up and you get cultures, or you see in the mucus, there's all kinds of eosinophils. It's one of the blood cells, the white blood cells. Well, in that type, there is a biological that's out. There's several now. Sincare and Nucala are approved for use in asthma that's eosinophilic, but it helps people with a sinus disease too. So there are biologicals that are coming, but they're not approved for everybody. Now there's some drugs for allergies that are biologicals that are going to help. Whether they help sinuses, I don't know. We've talked to companies about maybe putting these things in rinses and cutting out that inflammatory response. We've talked to them about IgA. Here, to get all this IgG, you have to throw out your IgA. Well, IgA is what you need in your sinus. So why don't we make a rinse or a mist and spray an IgA? It's a great idea. No one's done it. Hans Ochs from Washington always talks that he used to take his patients and tell them, when you give your immunoglobulin, take a 1 or 2 mLs of it and squirt it up your nose. He says it helped. No one's done a study on it. So there are things that could be done, we could be looking at, but we really haven't done it. And I think there's things you could do. So I don't know. It's tough, but if you understand the process, it isn't an easy thing to break. Maria is a SCID patient, had normal T cell function, no B cell function, and is IgA deficient. Why doesn't immunoglobulin manage it, and can you discuss Prevnar? Okay, after bone marrow transplant in a SCID baby, we don't always get full immune reconstitution. And a lot of the kids that were transplanted for SCID still have B cell deficiency, and they still have antibody problems. So they remain on immunoglobulin. And you're right, they don't make IgA, so the mucus is deficient of a bouncer. So antibody that we give in replacement is IgG. That doesn't go out into the mucus. So people with antibody deficiency aren't protecting the sinus, even though you're giving IgG in the blood. And so we always have problems with sinus disease, even with good replacement with antibody, and going up on the dose doesn't seem to help the sinus. And the same thing for the bowel. You have a lot of bowel disease in immune deficiency because there's no IgA to help protect against the bacteria. So this is a difficult problem, but if you manage with understanding of what's going on, you can add a bouncer. Prophylactic antibiotics shifts the balance and reduces the incidence of infection about half. And so there's ways to do it. Nasal irrigation, steroids in the nose, these things help. And to discuss Prevnar, I think we already talked about it. The Pneumovax is all carbohydrate. The Prevnar is conjugated. And in a child that had a bone marrow transplant and doesn't have B cells, they're not going to respond to the Prevnar. So that doesn't help there. But if it's somebody who does have B cells and just can't make antibodies to carbohydrates, it's a way you can get around it and trick the immune system to respond. What effect does sinuses have on ears? Well, the sinuses are connected to the ear. Your eustachian tube goes from your middle ear right down to the back of your nose. So if there's mucous membranes that swell, it'll plug that eustachian tube. So it's like going up in an airplane and your ears get plugged because there's pressure. Well, that's what happens when you close up the eustachian tube. Now that will lead to fluid in the middle ear, and it makes you prone to infection. So that's how they're related. And the mucous membrane is the same on a eustachian tube as it is in the sinus. So they're very much related. What effect does weather have on sinuses? Well, anyone who's had a sinus infection knows when the weather changes, it hurts because the pressures change. The same thing as going up in an airplane. You have a sinus infection, you have to fly. It's pretty miserable because the pressure has nowhere to go. And so, and if it's in the ethmoid or sphenoid sinuses, it gives you a horrible headache. So the pressure changes really do affect it. So it is a problem. That's the end of these questions. I can take any more if you want after, or you want to ask. Anything to do with? Oh, the tear ducts. Yeah, again, your eyes water, and there's IgA in the tears, and that goes down a drain right to the back of the nose. So when you cry, your nose runs because it's a drain. So it does. So you get sinus disease and inflammation. A lot of times you get the pus and junk coming out of your eyes because it goes up that tear duct. It's just a gutter. It's just a drain. So they're definitely related. Yes?
You're saying that IgG doesn't really help so much, but when I first started IgG, I had a schedule for sinus surgery. They took a scan of me before I started IgG. They took a scan the month before, 6 months later, I was supposed to have surgery, and they said I'm totally two different people.
So you cleared up.
I cleared up, but I still have, I would say, chronic, but it's not as bad as it was.
Sure, and the question is, I said that IgG really doesn't help sinus disease, and she had a sinus problem and was going to have surgery, and she was found to be IgG deficient, so went on IgG, and 6 months later when they looked, the sinus had improved dramatically.
And I have no A.
You have no A. So it does help. I'm not saying it doesn't help, but it's often inadequate. So you can't replace that IgA in there. So there is, if you look at mucus, it's leaking from your blood. There is some IgG that leaks out. It's not, but it's hard to get much in there. And then when you get this chronic disease, it's hard to get any in there because it just has such a large barrier you got to get through. So it isn't great. Yes. Yeah, reflux is a big problem, and we didn't talk about managing it, but usually we start with antacids. Over-the-counter antacids. Thing is, if you get Protonix or Prevacid or things over-the-counter, they're usually about half the dose that we would use prescription-wise. So a lot of times with this, if someone has what I think is reflux symptoms, waking up in the morning with congestion, all that, just tell them to take 2 of the over-the-counter. Go for a month and see if it clears up. And if it does, you know that it probably is related. And you can talk to your doctor about a more chronic management. Sometimes reflux is really hard to treat, and it takes more, so you talk to the GI doc or your primary care doc about some of the things you can do. Yes? The question was about fungus in the sinus. Well, there's a lot of controversy on what role fungus plays. And there was a study at Mayo Clinic where they did washings of chronic sinus disease, and they found a lot of aspergillus and a lot of fungus. No one's ever reproduced that. But for a long time, everybody was treating chronic sinus disease with antifungals based on that. It didn't really help. So I think people have gotten away from it. Now, there are times where you'll get fungus out of the sinus, and you need a surgeon to go up and get a culture so you know what you're treating. It's usually not invasive fungal disease in somebody who has good neutrophils. It's usually sitting on the surface. Spores of fungus are irritants. So if you get mold in your house because you had water damage, it can be really irritating to mucous membranes, and you can be coughing and having junk in your sinus all the time until you clear that out. So it does play a role, I think, more as an irritant than actual infection in most people. Now, there are times that's different, and you get fungus that grows in there, and it can be a real problem without a surgeon. Yes?
The IgA you're talking about in the mucus, is that different than what they test in your blood for?
Great question. In the blood, we test for IgA, and we can measure it. In the mucus, we're not measuring it. It's very difficult. We used to do studies at the university where we wanted to measure IgA in the mucus. So we'd have people wake up in the morning and clear their throat, and then they'd spit all day and not swallow their saliva. Then you'd have to put it in and do a dialysis to boil it down, and then you measured it. It was very cumbersome, and there isn't an easy way to measure the IgA content in mucus. So some people have normal IgAs in their blood, and they have no secretion because they're missing a secretory piece. So it's not an antibody problem. It's actually a different protein that's missing. And so it's very hard to know.
Thank you.
Yeah.
When it comes to prophylactic antibiotics and treatment, should we use different ones or the same?
Prophylactic antibiotics are used a long time. And you don't want ones that are good for treatment because then when you have to treat, you limit your choices. Plus, you change the bacteria in your bowel, so you get more diarrhea and side effect from the antibiotics. You don't want broad ones because you don't want the resistance. So for prophylaxis, we use narrow-spectrum antibiotics that are limited, and they help avoid some of the sinus from starting to get infected. So I use amoxicillin, which doesn't treat very much, but it's amazing how effective it is. We cut infection rate about half. And I think it decreases the load of bacteria that causes inflammation. I'm not even sure that it's an antibiotic effect. I think it has to do with breaking some of that inflammatory cycle. But other ones are Zithromax that are used 3 times a week. That has an anti-inflammatory property, but it covers a lot of the common bugs. And then some people will use sulfa drugs, which also can decrease inflammation, and they're good. But then you keep the powerful antibiotics, the broader spectrum ones, Augmentin and things like that. You use those for treatment. So it's a different approach. But I still like to have pretty high levels at least once a day for prophylaxis. Otherwise, you don't kill bacteria. Yeah.
Are you suggesting that if one use steroid doesn't work to try another? And if so, what would be the appropriate sort of course of therapy before you would move on to the next?
Are there differences between the nasal steroids? Yeah, they have different compounds. They have different aerosolization. They can be delivered different. They taste different if you're a kid, and most people, kids hate Flonase because it's gross. You want things that are dry and not watery because it drips down the back of your throat. There's differences between the steroid preparations. They all work similar, probably not any major differences, but the tolerability may be different and the delivery mechanism. One of them I like a lot is this Q nasal. You put it up the nose and push it, and it has a big puff. So kind of, whoa, and it gets up there. It's really good. And it's dry. It doesn't drip down the back of the throat. Flonase is commonly used, but it's very harsh steroid, and it dries out the mucous membrane. So we have had patients that eventually erode a hole through the nasal septum because of overuse of nasal steroids. So you have to have some caution. But yeah, you try and see what works best. Nowadays, you hardly have a choice if it's prescription because your insurance company will say what they want you to use. And a lot of them are over the counter. The only one that's a little different is something called Xyzal as an antihistamine compared to other antihistamines. So that is a different one. And the steroids, I'm not sure that I've seen a lot of clinical differences. So you try them and see. Yeah.
In people with common variable, is there a success rate on sinus surgery? Most of the people that I asked, they said, oh, it's terrible, I shouldn't have done it. Very few have said it's been successful.
Sinus surgery in people with immune deficiency, you can fix the structures, but you're not fixing the problem. The problem is your bouncer. And so, it does help acutely. It may give you some relief for some months, but eventually that inflammatory process is going to start up again. So you're back where you were, and it doesn't last. And in kids especially, they close up pretty quick. So there's times that sinus surgery gives you relief, but it's hard to get permanent relief from sinus surgery. Yeah.
Do you think xylitol works? You've gotten to see that?
Yeah, it's fashionable now. Xylitol, it's a sweetener, and I don't know why, but a lot of people feel it does help. We've been using it in people with Sjogren's because it helps you salivate more, and it does help mucus. So, yeah, I think that it's probably worth trying, and it's helpful. I don't know if it's any better than anything else. Menthol alone is very effective at causing you to secrete more moisture into the mucus. So I like menthol as something. It smells good. My mom used to put Vicks Vapor Rub on me. It worked. And so these home remedies don't cost anything. So there's no pharmaceutical industry pushing it. So you don't talk about it anymore. They'd rather write a prescription for a drug that costs you $500 than to tell you to go home and put a little Vicks Vapor Rub on. But these things work. They help. Yes? So if you have an allergy to sulfa, I really like Zithromax as a stronger antibiotic than amoxicillin if you're penicillin allergic. Otherwise, amoxicillin I like. It's my favorite. Other people have others. But the studies with Zithromax are interesting. It really decreases inflammation. And it's nice because you can do it 3 times a week. You're not taking pills every day. And it seems to work pretty well as prophylaxis. But then you have to switch to something to treat when you do get infected. But you don't need to have sulfa drugs.
What dosage of it?
We use 250 3 times a week. Now, in the chronic lung patients, sometimes we use 500. There's some potential side effect with a higher dose, but it's safe in most people. But the 250 3 times a week works pretty good.
Why do people with allergies, how can you have CVID and allergies?
How can you have CVID and allergies? By making IgE. So you do have people with allergies, a lot of allergies, because your immune system is not making the type of immune responses you need every day. It's disordered. And so some people you have regulation that shifts one type of immune response to another. And if you have something wrong with that, you might constantly be shifting towards an IgE response, and so you have much more trouble with allergies than somebody who doesn't have that problem. So that's a simplistic way of thinking about it.
So if you have low IgE or low IgA, that determines whether or not you're going to have responses to those immunoglobulins.
I guess I'm not understanding the question.
If you don't produce, you can't mount a reaction. If you don't produce IgE, that means you won't have allergy.
What people call allergy is an IgE triggered release from the mast cell. It's histamine release and mediators that cause swelling and fluid leak. So that's what a classic allergy is. There's intolerances which aren't IgE mediated, which sometimes people mistake as allergy. So I don't know if that helps clarify it. The session is done. I'm happy to answer questions up here for people if you want, but thank you so much.